and they said the pros and cons. Direct anterior approach gives you early functional outcomes with shortened mean length of time, but they are really associated with patient early, then this may probably the incision to use. But now, so from all this, we get an idea that it basically depends upon the patient's suffering. And we'll see what's the worldwide practices. Now, look at the American registry, and I couldn't find any evidence, sort of any mention of incisions in this. But this was a survey done in America for the members of the American Association of Hip and Knee Surgeons. And if you look at this posterior approach, 2009, 2020, has dropped from 65% to 46%, and lateral approach from 20% to 9% in 2020. But if you look at direct anterior approach, from 12% to 45%, and I think this is probably the fact that there's a culture of same-day total hip or joint replacements in America, just try to decrease the cost of the surgery. So it is said that although the operative cost of the direct anterior approach are higher as compared to the other approaches, but the and again, they looked at different ones. So this was incision. So this is primary total cemented hip replacement, and this is uncemented, and this is hybrid. And if you look at the posterior approach, it's around about 74, 83, maybe more than 80%. And Harding approach is roughly between 15 to 25%. But if you look at the rest of the approaches, and this data is from UK, the direct anterior approach is roughly maybe 1% or less than 1%. Operated by either posterior approach or the Harding approach, the predominantly being the posterior approach. Look at the Swedish Arthroplasty Registry, their report in 2022. And again, they had the posterior approach, and this is direct lateral in a lateral position and a direct lateral in a supine position, and then others. And this was their graph starting from 2000 to 2020. And if you look here, now this is the posterior approach. And if you look here, so this is about 60% mark. So the posterior approach has been consistently between sort of 55 and 60%. The rest, so this green and black is so roughly about 95 to 97% or and this is our own registry. So fourth is, so this is the fourth here, so about majority of the hair we do it to the hoarding approach, and maybe a little bit to the posterior approach. So in summary, direct posterior approach and direct approach are the commonest approaches practiced throughout the world. Hoarding approach is the commonest one, which is done in Pakistan. The direct anterior approach will give you better patient for 6 weeks, but after 6 weeks the results are the same. And throughout the world, probably the posterior approach is the commonest one to use. But obviously the incision you use will depend upon your training and experience, and you should try it, and as the data suggests, we should try to stick to what you do best. Thank you for your attention.
I think an excellent talk by Professor Zahid Askar, and I think the key message was do what you are familiar with and do what you are an expert in. Don't just try to copy the data that the success rate in USA is posterior approach, because they are doing 83% for all uncemented hips, so we should just keep following it. Do what you are best in, and do what you can revise your surgeries as well, and you can extend it. So I think that's the key message. Further, we will discuss at the end of the session. Now, the next, I would like to invite Professor Parvez Mahmood Hashmi.
Thank you very much, Shahab. Respected colleagues, Assalamu alaikum. I'm going to talk about two things. One is a salvage procedure. We commonly nowadays called salvage hip arthroplasty, especially in hip, failed hip surgery. The other would be total hip replacement in dysplastic hip, especially in a type 3 and type 4 Crow procedures. So, we know that the incidence of a hip fracture is expected to double almost over the next 20-25 years. And the three common fractures and their modalities of fixations, everybody is aware of that. If it is an intracapsular fracture neck of femur, depending upon the degree of displacement, we offer various treatment. One is AS screw or cannulated screw fixation. And if it is a displaced fracture, depending upon age and functional class, either it could be hemiarthroplasty or total hip replacement. Now, if it is an intertrochanteric fracture, most of us, they actually do fixation with dynamic hip screw, DHS, and nowadays there is an upward trend towards a proximal femoral nail, and which has to be, before actually inserting that nail, one has to perfect his technique, because there are a lot of failures which I am seeing in PFN surgeries also. The third category in a proximal hip fracture is a subtrochanteric fracture, and we know that conventionally people, they have been using DCS, DHS, proximal femoral nail, and even then there was an era of a proximal locking femoral plate also. But ultimately that failed, and now hardly anybody uses that. Now, incidence of hip fracture as it is increasing due to aging population, and osteosynthesis of these fractures is also increasing for a better outcome, for an early mobilization of patient. But you see, the fixation of this failure osteosynthesis, it is increasing day by day because of a number of reasons. But you see, for a femoral neck fracture, it has been reported to 25 to 45%. For pertrochanteric fracture, one of the paper has published that 56% of the failure it can happen. So the various reasons for these failed hip surgeries, they are quality of bone like osteoporosis, unstable fracture, comminution, inadequate fixation. Our young budding surgeons, they are actually doing it, and sometimes they are doing it without an image intensifier, especially proximal hip fracture or AO screw fixation, and they end up not getting an optimum fixation in those cases. So there may be a faulty position of implants also in these cases. So salvage total hip replacements, that yields an excellent result in more than 70% of the cases. Technically, we know that it is much more demanding and challenging, and increasing difficulty arises especially when you see the fracture, proximal femoral fracture, which has been fixed previously. You need to encounter removal of implant first, then you may encounter non-union or fragmentation or maybe a malunion also. Then the difficulties, they are also associated with a prolonged time, and there is a excessive blood loss in most of these cases, and there is a high rate of post-operative dislocation and infection also. So these are challenging cases to deal with. Now, just an example of these actually hip fractures, like DHS failed Ostermoor hemiarthroplasty, proximal locking plate for a subtroch fracture, AO screw fixation for fracture neck of femur. These are the few examples we will see in a minute. So management of a failed hip fracture, it depends upon the various factors. We know that the quality of bone, degree of osteoporosis, fracture configuration and accumulation, and underlying infection. Then one has to evaluate what is the condition of acetabulum, what is the condition of proximal femur also. And it also depends upon the experience of a surgeon who is dealing with it. So the option at these stages, depending upon the age and functional class of patient, there are two options. One is either you go and revise your fixation. The other option is you do a salvage hip procedure, and that would be a Revian total hip arthroplasty. Now, it is nowadays considered a choice of procedure for a better outcome, early mobilization of patient. And indication for these salvage procedure, they are when patient is old with an osteoporotic bone, when there is a damage in non-salvageable femoral head, destroyed acetabulum, and underlying arthritis in the hip joint. And as I said, the choice of procedure on the acetabular side is usually, at least my choice is to use a dual mobility cup. And if some bone grafting is required on that side because of a acetabular damage, I will do that. But on the femoral side, one has to use a stem with long stem, a femoral component, modular or PFR, and it may further require fixation of great tuberosity along with a sort of a tension band wiring concept with a cable or with a trochanteric plate also. And so all those sort of gadgets should be available at the time of surgery when you have planned this kind of a surgery. So our residents, they are conducting a study just to determine the frequency of a failed hip surgery presenting at AKUH, and especially they are trying to find out the various factors responsible for failure, and they are trying to comparing with the international. This study is ongoing, and so you see the data is being collected, and so far they have collected a data of 1,466 consecutive total hip replacement from January to 2011 to 22. And they, apart from demographic data, they are looking at the osteoporosis and certain other factors like what was the reason of failure, trying to evaluate those x-rays if they can determine the cause of failure in those cases. So all the patients presenting to AKUH in whom primary total hip failed, and subsequently all other actually total hip replacement, they were done from this 2011 to 22. So many of these cases, they were from our own institution, and some other cases, they were from the other institution also. So the total number of cases, they were 1,466, and in failed hip surgery, we have 152 cases, and there were incomplete record regarding 9. They were, and from AKUH, we have a 32, and from the outside, we have 122 cases. So few examples. This is a failed proximal hip fracture which was fixed with a dynamic hip screw, and you can see the screw has cut through and it is violating the acetabulum, and the fracture is also in a malunited position. So here you can see on the one side acetabular cup was used, and on the other side we had to use a long stem with a sort of a PFR configuration, and to restore the abductor mechanism we had to use a cable. So another case in which implant failure occurred, which was removed, and then the patient was left alone because of an infection, and when he presented, he had a shortening and involvement of the right side of the hip, limp, and inability to walk. So in this case, again, total hip replacement with a long stem And during that, we had actually encountered vertical split, which was fixed with the cerclage wire, and the abductor mechanism was again restored with the cable. So another case of a cut through DHS. Here we see that once the dual mobility cup was available, then we started to use more frequently dual mobility cup for such cases and with the long stem, so that we can get patient early out of the bed and mobilize them. So another case in which there was infection, initially implant was removed and infection was treated, and following that, then we had to do with a long stem and dual mobility cup total hip replacement. And other case you can see with a failed proximal femoral neck fracture fixation with the screws, where the screw was broken and those were removed. And then when the patient presented, he had a stiff hip and walking with a limp and pain. So that was converted into a total hip, and that's the outcome. Another case of a failed DHS. Here we had to actually put a long stem with a dual mobility cup, and again hip abductor mechanism restoration with the cable was done. Of a protusio also, then we had to convert total hip replacement, and most of these cases require long stem and look at the plate also. But in this case, we will not just PFN, and you can see initial fixation, and after ambulation it failed miserably, and then we had to convert it in a long stem total hip replacement with a dual mobility cup. So mechanical failure was the most common reason for in our series, and second common element which we encountered, it is an infection. So the most common index surgery requiring Revian hip arthroplasty, it was actually Ostermoor, and followed by which we encountered. Still actually study is ongoing and they are completing their results. Predominantly females older than 60 years of age. So salvage hip arthroplasty is an excellent procedure to improve the pain and ambulation of patient. It improves the quality of life of patient. It is quite demanding and challenging for an arthroplastic surgeon. Surgeon should be experienced, and all the gadgets should be available at the time of a surgery, so that he should be able to handle any bone deficiency on acetabular side, on the femoral side, and should be able to treat it properly. Thank you. Next, I think I will take the question at the end of next session.
continue with the
Yes,
talk.
yeah,
You still actually
exactly.
have 3 minutes.
Yeah,
Yeah,
I
but
know. Exactly, I just wanted to, for the sake of time, I just wanted to finish early. If you can start. So this is another difficult and challenging procedure, total hip arthroplasty in a dysplastic hip. In our institution, I am going to share with my own experience and my colleagues who are doing actually this work at AKUH. So we know that the hip dysplasia, it is not simply a dislocation of hip. There are 4 grades of hip dysplasia, and it can cause a variety of disorder subsequently which lead to abnormal development of hip joint, especially altered anatomy, and we will go through that. What are the changes which are occurring on the acetabular side, on the femoral side, and then correspondingly bony changes. There are actually soft tissue. So if you look at 1.4% is the incidence of a developmental hip dysplasia, which has been described in the literature, and 68% of osteoarthritic hip, they require actually, because of a hip dysplasia, they present in the clinics and they require surgical intervention. But 26% of all the total hip arthroplasties, they are being performed for osteoarthritis. So mostly it is common in the females. And if you look at that, especially in a hip dysplasia is common in the firstborn female, if they have a feet presentation first, and if there is a family history and there is a flexibility, the chances of hip dysplasia, they are high. Now, there are 2 well-defined classification system, and everyone is aware of those. One is the Crow classification system of a hip dislocation, as the head actually moves in an outward direction from, you can see here, one teardrop signs to the medial border of neck of femur. This is a slightly displacement, or sometimes you don't see displacement when the X-ray is done in a frog-leg position, but if the X-rays, they are in a standing position, you may clearly see this space, and you can pick up actually grade 1 hip dysplasia. And in grade 2, there is a 50 to 75% of the displacement, and in grade 3, we see almost more than 75 up to 99% displacement. In grade 4, there is a frank dislocation of the hip joint. And similarly, in the X-rays, they are representative X-rays. One can see these 4 grade of a Crow dislocation. Now, the other classification, Hartog-Philakidis classification, that has divided into 3 categories. That dysplastic hip, when you get an X-rays in a epi-standing position, you may find some subluxation. Other, he has found that there is a subluxation, and the third category is a frank dislocated hip. So these are the 2 common classifications described in the literature. Now, what are the actually various treatment options for these, apart from a total hip replacement, which is a final choice of procedure? People, they have been trying a pelvic osteotomy, like periacetabular osteotomy in a younger age group, salvage pelvic support osteotomy, hip resurfacing, but ultimate treatment of choice for a patient with an end-stage hip arthritis is a total hip replacement. Now, the reconstruction of hip joint, as I was telling you, that it is a quite demanding and challenging, especially when there is a distorted anatomy and there are high rate of a complication encountered in these cases. So results of a cemented and uncemented implants being used in a developmental hip dysplasia for a total hip replacement, both they are promising. But the surgeon has to be aware of all those sort of a complication and should be able to handle those complications perioperatively, especially on the acetabular side as well as on the femoral side, and then he should be able to tackle those any other soft tissue contractures. So a paramount importance is that the surgeon should have a good expertise and experience while dealing such kind of doing such kind of procedures. So abnormal bone morphology, growth, orientation, and soft tissue alteration, it distort the normal relation between the acetabulum and the femoral head. And the THA in this population, it can be unpredictably challenging. apart from morphological changes, one should consider the young age of patient and need for any revision surgery. So understanding of common acetabular and the femoral morphological abnormalities will definitely help the surgeon in planning of hip arthroplasty in these cases. Now, young age is obviously a patient has a painful hip and they present in a younger age group, especially in a Crowe type 3 and Crowe type 4. So one should be familiar that if he is doing total hip replacement, what kind of implant he would be using in those. And apart from that, surgeon has to keep in mind that there are morphological changes which are occurring on the acetabular and the femoral side. So there may be deficiency of bone, especially in the interior column and the interior wall, it may be a deficit. So leg length discrepancy is another issue. And then contracture of muscle apart from a soft tissue contracture. And one has to see that there is abnormal anatomy of a proximal femoral region which especially increase anteversion. So once you are trying to plan such kind of a surgery, you need an elaborate planning preoperatively, and you need to make sure that all sort of implants they are available, and you should have a 3D concept in your mind that what are the abnormal changes on the acetabular side, on the femoral side, and to determine leg length discrepancy, one should get an full AP standing X-ray and should plan it where his acetabulum would be placed and how much shortening or derotational osteotomy he is going to do on the femoral side. So the various sizes of cup, usually the cup sizes that would be a smaller as compared to larger cup, you may not be able to use it because you have to create a new acetabulum in these cases. And 3D preoperative planning, it can be used to assess the anatomy of acetabulum and the proximal femoral region. This one, it will also actually highlight any deficiencies of bone on the acetabular side, especially on the interior column as well as on the interior wall. And you need to plan it. My favorite approach for this kind of a thing, and maybe most of you will also agree that the posterior approach, extensile approach, it gives you a better exposure of an acetabulum on this side. So you need to identify the true acetabulum and re-establish the normal center of hip. It is very, very important to identify that. How to identify that? Once you actually do a femoral osteotomy, you must trace a ligamentum teres and try to go to the acetabulum with the cartilage fossa. Inferior capsule is usually quite thick, and you have to do need to actually do an arthrotomy going through the interior capsule and try to find superior, interior, and inferior borders of an acetabulum. And it takes a lot of time to identify those original acetabulum, because original acetabulum may be a small size of a coin. You may not be actually able to see that. And once you start with the superior, I usually start with the superior dissection, then come interior, and then go to the posterior, identify the ischium and anterior superior iliac spine, and the superior pubic tubercle. So my exposure is most of the time, it's a wide exposure so that I can find the whole acetabulum on that side, and then clear any soft tissue from that acetabulum. So at the end, you would be able to find only a triangular fossa which is filled with the fat, and you have to create a new acetabulum. So if pseudoacetabulum is mistakenly, it is identified as a native one, then your hip of center would be changed. You may place the cup in a higher position. So you have to be careful that where is the exact acetabulum, and here you need to have a help of an image intensifier. So without image intensifier, you would not be able to locate sometime. It is quite difficult. And then once you have identified, you are creating the cup, then medialization of anatomic hip center is very, very important to do a controlled reaming, bit by bit, gently, so that you should not penetrate the medial wall. And one procedure which people they have described is a catalloplasty, that osteotomy of medial acetabulum wall and medial advancement. Now people, they are moving away from it because of a lot of complications, and those complications, they have been a cup migration, loosening osteolysis, failure of internal fixation, and protein of a cup in the acetabulum. And it was popularized 20 years earlier, but hardly people they do it. So as I said, posterior approach, soft tissue releases, and my soft tissue releases, with the incision, first is removing the gluteus maximus from the ischial tuberosity, then superiorly subperiosteum elevator of hip abductor, release of both head of rectus femoris, iliopsoas stenotmy, and wide exposure of acetabulum. Then once I have identified the acetabulum, or I'm trying to create a new acetabulum with a controlled reaming, and here I need sometime a bone grafting from the femoral head, whatsoever head is available, with and fixation with the screw, so that I can give a posterior coverage to that. And finally, a cup is placed. Nowadays, I try to get a tri-flange cup with a dual mobility placement. That helps a lot to have a secure fixation on that side. So on the femoral side, we know that there is an increased neck shaft angle, and the anteversion is increased, and sometimes you encounter that this is up to 40 degree of anteversion. And relatively, there is small diaphyseal diameter. Anteversion, it can be adjusted precisely, especially if you have a preoperative 3D picture, and you have to correct the leg length discrepancy also. You have to do a derotational osteotomy, maybe some shortening also, and then with a fixation along with a trochanteric plate. So the customized femoral prosthesis based on the principle of computer-aided engineering, it can be used, but in our setup whatsoever, we have pediatric hip stem sometime. In older days we have been using it, but sizes, small sizes, they can be used on the femoral side. So in a soft tissue, we see that there is a thickened capsule, and we know that the function of hip abductor is also impaired when you do a subperiosteal elevation, and those muscles, they are already shortened, especially in a high dislocated hip. So you have to be really brain enough to do an extensive soft tissue releases, stenotmy of adductors, parts of iliotibial tract, a release of iliopsoas muscle, release of attachment of piriformis muscle and the hamstring, and then gluteus maximus, as I told you. So this is just an example where you can see it's a grade 2 here you can see grade Crow type 2 hip, dysplastic hip. And here, what I had to do, if I can go back, you can see here, there's a quite thick acetabulum wall. So I had to do a medialization and then a bone grafting here fixed with a one screw and with this flange cup of a bipolar. So you see, we were able to restore almost a normal center of hip and rotation. And this is at the perioperative, some of the picture. One can see the shape of head. One particular thing was that as the weight bearing was especially on the superior capsule and the labrum, and you can see this thick labrum superiorly. And this is the excised labrum only supralaterally. It was a quite thick and huge, almost 2.5 centimeter. And this is perioperative picture. So, at least in our country, there is very little literature available regarding this type 3 and type 4 of a Crow type of hip dislocation. And we have quite a big series. Collectively, 3 people are doing it. And here is just in a preoperative planning, few things one has to determine: proper X-ray, templating, and then you need to have all sort of implants, and one should have a pre-thinking process that if there is a need for bone grafting, need for any cables and those things. So it is a retrospective view. I will just go through, I will omit these inclusion, exclusion criteria, how the data was being collected, and our resident, they are using Harris hip score to determine its outcome. So there is a total of 53 patients. They have been included over a period of 9 years, and 11 patients, they had a bilateral DDH, while 42 had a single unilateral DDH. And the total number of dysplastic hips which we have done, they are 64. And mean age of our study population is actually, you can see it's a 41 plus minus 9.2, and the age ranges from 25 to 67 years. And mean duration of symptoms, they were recorded from ranges from 4 to 5 years. So this is a male to female ratio. Females, they are predominantly in our study, and bilateral, they were 20, as we said, 11, right to left side. In a Crow classification, we had actually type 1, 20%, type 2, 35%, and type 3 and 4, they are the majority in like 45% collectively, both. This is another classification, and you see acetabular deficiency was noted medially in 5% and postosuperiorly in 5% and posterolaterally in 15% of the cases. So none in 42% and interior in 33%. Bone grafting was used in a 52% of the cases, not in 48, which did not require. And here for a hip abductor mechanism, trochanteric plate and a cable, this was used in almost 10% of the cases. And then cerclage or cable in a 22%. Femoral osteotomy was in 10% of the cases. Not every case required osteotomy. And our preoperative limb length discrepancy, it definitely improved with this surgery. And complications, we have a few complications like wound infection, hip dislocation, and the sciatic nerve neuropraxia, which we encountered. And mean Harris-Hip score definitely improved from a 40 to almost 85%. And based on the results of our study, total hip arthroplasty is a safe and effective procedure for DDH even in a developing country, and outcome is comparable to international literature. Now, few case examples I'm going to highlight. So this is a 45-year-old female who had actually right-sided type 2, Crow type 2 hip dysplasia. And this is the postoperative with the dual mobility cup, total hip replacement. Another case on the left side, it is type 2. And again, this was with the dual mobility cup and with the bone grafting, sandwich underneath the screw for flange of a acetabular cup. And other case on the left side, it is a type 4, Crow type 4, 40-year-old who had a painful hip and limitation in walking. So in this case, again, a dual mobility cup was used with a long stem. This case, type 4, where there was a leg length discrepancy apart from a elongated crooked proximal femur. So we have to do dual mobility cup, osteotomy, derotational osteotomy, little shortening, and then apart from inserting this, we had to do a trochanteric plate to restore the length as well as to allow early weight bearing. So this is another case, hip which was treated somewhere else. He was a young 22 years old gentleman who had a painful hip. So we had to reconstruct acetabulum with a dual mobility, and part of head was used as a bone grafting. So this is a lady who had a Crow type 4, 35 years of age, and she had a bilateral hip pain, difficulty in walking. So we did a simultaneously both hip replacement in this lady. This is a 3D CT, and in both cases we had to do bone grafting and dual mobility cup replacement. It is almost now 6-7 years down the line. Can you run the video one by one? Yeah, bilateral. The last case, I just bilateral hip, last case. This lady is from Quetta, school teacher, and this year early we had a city-wise meeting. We asked her to make a video and send to us, and she actually was kind enough to send this video. Next वाली आप चला दीजिए. Okay. Thank you. Stop it. Okay. Now there are any questions? I'm here.
Talk.
No. वो ले ले जरा.
Thank you, sir. Excellent talk. My name is Dr. Orthocon. Especially in CRO 3 and CRO 4, what will be the future of the abductor mechanism? They come with the abductor lurch, and are they improving with the time? Are the abductors are improving? Are the power of the abductors are improving? I have seen a few cases, and they come persistently with abductor lurch. So I want to know about the abductor lurch in CRO 3 and CRO 4.
Yeah. Excellent question. You see, there's a shortening on not only in the soft tissue, on all the surrounding muscles. Those are the dynamic structure, and the abductor muscle, they are the key. I usually do subperiosteal elevation, almost couple of centimeters superiorly, posteriorly and anteriorly, so that the still muscle attachment is there. And you allow initially with the partial weight bearing, slowly and gradually they do progressive weight bearing. And abductor lurch, it takes 9 months to a year to go away, in my experience. And still some people, they will actually sag on that side. In an older age group where the people, they have a leg length discrepancy, they have actually some fixed spinal deformity also. And when you get an immediate X-ray, you will see there's a pelvic tilt is still persisting. And once they come after a year and so, that the amount of pelvic tilt decreases slowly and gradually. It does not actually resolve immediately. Walaikum salam.
Placement in dysplastic hip.
Yes.
So in type 4 dysplastic hip, sir, leg length discrepancy. We have experienced that when we do dysplastic hip in type 3 and 4, it is very hard to reduce, and then we reduce and it dislocate easily. And it is, please describe this.
Yeah, you see, that's why I actually told you I'm very aggressive in doing a soft tissue releases. And initially, you need to detach your gluteus maximus from the gluteal tuberosity. This is the first actually component. Then when you do arthrotomy, I always do hip
working on that center of rotation for last 30 years. So it's not absolutely necessary to.
Sir, in long-standing failed DHS, failed proximal femur fractures, when there is a combination, we have observed that there is some difficulty in bringing the abductors to reconstruct that. We overcome this problem.
It's a pretty good question. You have seen actually my cases. Almost invariably, in all cases, I have used a cable. So not only I use actually certain tiger suture to bring it down and try to keep the bone in contact with that. So the cable goes to the soft tissue, brings the greater trochanter lower down maximally. So that's how you actually restore the hip abductor mechanism. Without restoring hip abductor mechanism, it is really difficult to allow early weight bearing. And in some of the cases, we had to use, apart from this PFR type of modular prosthesis with a long stem, trochanteric plate also. And I still remember in one of the cases in a city-wise meeting, Dr. Shahid said that maybe this is an overkill. But this is my apprehension that I need to actually control not only rotation, restore the hip abductor mechanism, and allow early weight bearing in those cases. Any other question?
Okay. I think if we don't have, then we. I just was impressed. The data that you, the first talk published, that out of 1,466 cases, 152 only reported were failed,
Yes.
which you converted to THR.
Yes.
So which is around 12%.
Yes.
And the data that you presented before that, how many get failed,
Yes.
was around 25 to 30%. So
Yes.
it's quite impressive.
Yes.
That was it those all majority your AKU cases or?
No. Yeah, I told you that 32 they were from the AKU, 120 they're from outside. Okay. So total of 152 cases, we have a data of 152 cases.
It's still quite impressive data. Yeah. Okay. Thank you. Okay. We have actually some free papers by the colleagues. I don't know who's here among those. Dr. Zain Nasir or Dr. Abidullah, Dr. Muhammad Mustafa, you are Dr. Abdullah. And do we have Dr. Muhammad Mustafa? Yeah. Dr. Zain is not here. No. Okay, so could we please invite Dr. Abdullah to come and present his paper, and then one by one, I think next Dr. Muhammad Mustafa. Come in, please.
First of all, I'm presenting his paper on frequency of limb length discrepancy after total hip arthroplasty. So the objectives of THA are pain relief, improved stability and mobility, normal mechanics of the hip joint, and whenever possible, equality of leg length. So the pain relief and improved stability take precedence over the limb length equality. However, leg lengthening may be required to achieve a stable hip joint. So the LLD after THA ranges from 1 to 27%, and lengthening is more frequent than shortening. Both can be there, but lengthening is more frequent, and the mean post-op LLD ranges from 1 to 17 millimeters. So there can be some complications of LLD post-operatively, which can be back pain, sciatica, neuritis, dislocation, gait disorders, premature loosening of the components, and patient dissatisfaction. So in this study, 252 arthroplasties were performed elsewhere, as the reference is given, and there are 45% of the patients were having LLD less than 10 mm, while 28% were having LLD more than 10 millimeters. And another study, they were having discrepancy of 21.4%, while in our study it was 17%. So the objective of our study was to determine the frequency of LLD after THR, and it was a descriptive case series obtained from 60 patients. Although all patients were having osteoarthritis, and patients were re-examined on first post-op day for LLD after total hip arthroplasty. So as previously I said, that 17% of the patients were having LLD ranging from 0 to 6 millimeters. Most of our patients were having